The two video clips to follow are taken from a live surgery video from the German ophthalmic surgeons meeting in 2009. The first video clip starts with anterior capsule polishing using a special aspiration curette designed by myself and published in the GCRS 2006 December issue. The slit-like opening is docked to the back side of the anterior capsule to be then slowly moved back and forth when the vacuum has built up, thereby shearing off the LEC layer like a windshield wiper. Through each of the three equidistant paracenteses, 1/3 of the rexis circumference is reached at a time. Recommended fluidic settings are 10 ml per minute and 50 mm mercury. The small superior bypass bore slows down the speed of vacuum buildup when occlusion establishes, thereby ensuring a smooth capsule grasp instead of an instant bite. The number of passes required varies according to the differences in LEC adherence. Meticulous removal of all residual lens fibers is important, since these may entangle with the advancing posterior capsule edge. Regular Helon is now injected above the anterior capsule leaf in order to bring down and attach it to the posterior capsule. Then the central posterior capsule is flattened, thus creating a common planar capsule diaphragm. Then a 30-gauge hypodermic needle, bent bevel up, is tangentially approached to the central capsule, aiming at lifting up a fold and then perforating it. Other than usually taught, OVD is not yet injected through the slit created. Instead, the edge of the capsule slit is grasped with blunt capsule forceps, and the capsulorhexis is initiated. Only now is OVD injected in order to separate the anterior hyaloid from the posterior capsule. This avoids injection of OVD into the vitreous body should a firmly attached hyaloid have been inadvertently punctured together with the posterior capsule. The posterior capsule edge is then regrasped by forceps, and the capsulorhexis is completed with 2 or 3 additional passes. Using a blunt cannula, Helon is injected beneath the posterior capsulorhexis edge in order to circumferentially visco-dissect the anterior hyaloid from the peripheral posterior capsule. The advancing dissection line can thereby be easily visualized. Now the nasal capsular fornix is reopened and prepared to accommodate the leading IOL loop. The injector tip is inserted through the tunnel with a slip-oriented sideward to exclude tissue trauma, to then be rotated clockwise to allow the leading loop to exit horizontally and settle in the reopened nasal fornix. The exposed piston gently pushes on the temporal optic aspect in order to entrap it beneath the posterior rhexis edge, which prevents the edges of the unrolling IOL optic from touching the subincisional endothelium. In this live surgery case, the inferior optic edge happens to slip under the posterior capsulorhexis, which is easily corrected for by simply lifting it up with a spatula. Using a Y spatula to give the trailing loop, while a blunt spatula is positioned on the anterior optic surface, the trailing loop is also inserted into the capsular fornix while slightly rotating the IOL. After recentering the implant, the optic is entrapped in the posterior capsulorhexis by gently pushing on the optic periphery 90 degrees away from the IOL axis. After draining some of the OVD by depressing the tunnel bottom, and after hydrating the paracentesis openings, a coaxial I&A probe is inserted and the residual helon aspirated with the aspiration port pointing upwards and to the sides. Finally, the I&A probe is quickly retracted to allow the self-sealing corneal lip to shut down, thus excluding anterior chamber shallowing. The optic now centers within the posterior rhexis buttonhole, and the posterior capsule is seen to overlap the optic periphery while its edges undercross the haptic-optic junctions. The clip to follow shows additional implantation of a capsular tension ring. This is advised in eyes with a flaccid posterior capsule and may be done before or at any time during the capsulorhexis procedure. By distending the capsular bag, the posterior capsule is put on stretch, thereby radially realigning the vector forces as the prerequisite for controlled guidance and sizing of the capsulorhexis. Again, the central posterior capsule is engaged tangentially and lifted up to create a triangular flap. After filling Berger's space, which is patent in this case as evidenced by the string-like shape of the helon extruded, the peripheral hyaloidal capsular attachments are gently visco-dissected. In cases, hyaloid and capsule may be firmly attached also in the center. Therefore, care must be taken when initially incising the capsule and injecting OVD for hyaloidal capsular visco-dissection. Now the flap is taken up by forceps and the posterior capsulorhexis is performed. The anterior capsule thereby acts as a ruler and is followed at some distance, since, due to the greater elasticity of the posterior capsule, the posterior capsulorhexis will enlarge when deepening the central chamber. Notice the perfect stability of retroillumination and control of the procedure resulting from the patient fixating the microscope light under topical anesthesia. The posterior capsulorhexis is completed by peripheral visco-dissection of hyaloid and residual capsule. Since anterior capsule polishing has not been performed in this case, this is achieved through 2 paracentesis openings only. After slightly opening the nasal fornix, the IOL is again implanted as shown before. This particular IOL design is preferred because of its continuous haptic-optic transition, which allows the edge of the posterior capsulorhexis to smoothly slide along between loop and haptic rim while automatically being centered even within a decentered posterior capsular opening by the fornix positioned loops. The specific optic notch at the haptic base allows insertion of this 6 mm optic IOL through an incision as small as 1.8 mm. The procedure is again completed with optic entrapment into the posterior capsule opening by gently depressing the optic rim. Thank you for your interest in this procedure. I have no financial interest in any of the products shown in this video.